Hi, I'm Mark Nelson. I'm a consultant here in HIV at the Chelsea and Westminster Hospital, and I also work as an adjunct professor at Imperial College School of Medicine. So the Chelsea and Westminster Hospital is a very large unit. In fact, I believe it's the largest HIV centre in Europe, and we're treating around about 8,000 patients here. Nowadays, HIV is a very treatable infection. We have a wide range of agents which we can utilise to treat individuals. And perhaps more importantly, we've learnt how to use them appropriately. And some people say it's very simple. I think it's still quite a complicated disease to treat. It may be relatively easy if we're looking at first-line treatments when someone starts treatment for the first time. But unfortunately, some people fail those treatments, and then it becomes rather complicated and where you really truly need specialist knowledge. But the outlook for someone who's infected with HIV nowadays, if appropriately treated in a good centre by a good physician or a good team headed by that physician, is that they should live or even outlive the general population, someone without HIV, because of the monitoring for infections and other diseases which happen as we get older in the HIV population. Very small numbers of patients in this centre actually fail therapy. And when we talk about failing therapy there, I'm talking about virologically failing therapy, i.e. that the virus has rebounded through the drug treatments. The first thing we need to think about when we see an individual where therapy is failing is why are they failing? And there may be several reasons. It's actually very rarely, if at all, the drugs. I think the drugs are very, very powerful. The reason people are failing therapy is normally because of toxicities. Those toxicities are driving non-adherence, i.e. patients won't take treatments which make them feel unwell. And then what happens is the virus starts to reproduce. It's reproducing in the presence of the drugs which are trying to stop it reproducing. And then the virus changes. It makes changes in its genetic structure, which then lead to the drugs not working. We also have to look at other reasons, of course. There may be drug-drug interactions. There may be resistance there before the patient has started therapy, which means that the drug combination won't work. But really, the first thing to do is look at why they're failing. Secondly, we then need to see what drugs we may want to utilise in the future, which drugs will work, and how do we choose there? Well, in this country, what we do is a resistance test to see what changes the virus has made to escape from the power of the drugs and what agents we can use in the future. Now, resistance tests are often quite complicated to interpret. First of all, they're not 100% accurate. So they only pick up majority species of virus. So if the majority of the virus has those resistance changes, then we can see them and hopefully interpret them correctly in our choice of drug. But there may be other mutations, changes in the virus, which are beneath the surface, which aren't picked up by a standard test. And that may, of course, influence how our next regimen works. The next problem is you need to interpret those changes. And so as you become more experienced, you will recognize different patterns and very quickly say drug A won't work, but drug B is likely to work. However, there are further complications because change A may affect how change B affects drugs to work. And when you start looking at change A, B, C, D, E, F, and G, then it's very difficult for an individual to interpret. And therefore, what we tend to use is we plug those mutations into a computer program which will come out with saying drug X is likely to be effective and drug B likely to be ineffective. The problem we have is different systems will interpret it in different ways. And you need to be careful from what I said. It's likely to have worked or likely not to work. There is no be-all and end-all by looking at individual drugs and changes that the virus has made. So unfortunately, although we're very lucky in most of Europe, in the United States, to have the money to perform resistance tests, have the money to actually monitor patients frequently and accurately to how well the drugs are performing. We're lucky enough to have a wide range of agents. Others are not so lucky. If we look at resource-poor areas, there is a much smaller choice of drugs available, often governed by price. And unfortunately, cheaper drugs are not always the best drugs. So individuals may have more issues with those agents as regards adherence, as regards toxicities, and that may lead to a higher rate of virological failure. In addition, we monitor our patients here using a test called viral load, and the aim of the drugs is to stop the virus from replicating and for the viral load to be so-called undetectable. That doesn't mean it's not there, it means that it's at such a low level we can't detect. Often that's not available or is scantily available in the resource-poor world, so that people are identified as failing therapy much later than here. So we would look very quickly every 3 or 4 months at doing a viral load and say, these drugs aren't working. In many resource-poor countries, it's governed by clinical outcome or by changes in the immune system, which take a lot longer to become observable by the physician. Therefore, that virus will have been reproducing for a much longer period of time in the presence of drug. Therefore, the virus is likely to have made many more changes and have a much more complicated resistance pattern. The other issue is, where do we go to next? Many drugs aren't available in resource-poor areas. And often we only have 1 or perhaps 2 further goes at actually getting that virus suppressed. So it's really essential that we know what drugs, a combination of drugs, is going to give that patient the best option in that clinical setting to actually prevent viral replication in the future. In areas where resistance testing is not available or not widely available, unfortunately, the choice of agents is often done on a best guess. So we can have an idea of what is the most likely mutations which may have developed. That doesn't mean they are the mutations that have developed. And so really the best we have are really some guidelines which will say, if you've taken X, Y, and Z, your best hope as second line is to take A, B, and C. And so unfortunately that just leads to higher rates of virological failure, more resistant virus in the community. So that's bad not only for the individual, it's also bad for the population as a whole, because there's more chance of transmission of virus, there's more chance of transmission of a resistant virus, and that becoming predominant in that population. So I think for those of us who are working with RDI, it's an interesting system, and whether it's actually just a system for the resource-poor world or also for the resource-rich world is, I think, open to discussion. It's a system which is allowing previous experience of agents, antiretroviral agents, against various different types of virus, some with resistance, some without resistance, to actually take that experience and being able to give the physician some information based on what that patient has taken before as regards therapy, based on what's happening as regards the height of the viral replication at failure, what's happening as regards that patient's immune system, and putting that experience into a program which allows us to say, this is the best choice of drugs for that person. And so the RDI approach is to say, resistance tests aren't going to be available to all people in this world, but we can use the information which others have gathered as regards chance of success to really give that individual patient the best chance of success with those drugs which are available, and allow the physician confidence in their choice of drugs, that that's going to be the most successful choice of drugs for that individual patient. RDI has several partners, and what's important from those partners is that they are providing information. They're providing from their setting what happens when patients fail, what is the resistance test results, and what drugs have worked and which drugs haven't worked. Now, clearly, what's important is that we continue to give that information. It's no use giving information from 2005. We need to continue giving updates of that information, because there are new drugs coming through, new chances for patients. But also it's important that it's about partnership, and it's partnership of us with RDI, but also many other partners as well, some of which we can introduce. We do our own work in resource-poor areas, and we can utilise those partnerships to actually grow the number of people contributing data to the RDI project, which will allow us more accuracy, and also more accuracy not only for that patient, but also for the setting in which they are in. For the RDI project to work, you need huge numbers of patients. So it's really great news that the partners together have contributed over 150,000 patients' data. And it's really that large number of patients which allows us to be confident in the accuracy when we are predicting what is the best choice of drugs for individuals who are failing treatment. The models that are used by RDI are really very accurate. So they're accurate in predicting virological success at around about 80%. Now you can say 80%, is that really good enough? I think compared with other rules-based assessments based on resistance testing, those are actually quite incredible results. They actually say, actually this is better than a resistance test. Why isn't it 100%? It's never going to be 100% because, of course, the model is a model which is predicting that the patient will take all of their treatment. And, of course, unfortunately, one of the major reasons for treatment failure is people not taking their treatment. So no model is going to be 100%, but 80% is really quite an amazingly high level to achieve. So in this country and most resource-rich countries would use the genotype, which would be accurate in predicting outcome around 65%. We use the genotype, and then we use some rules to actually generate what is the best agent. Surprisingly, without a genotype, the RDI model predicts at 80% accuracy. So although this is a model which we're saying should be used in the resource poor world, actually you can see an argument for using it as a major contributor to choice of drugs in the resource-rich world as well. The model from RDI is available to anybody, anyone who's got access to a computer. So I think it is widely available. I think one of the challenges now is to make people aware of the model. And it's quite amazing. I travel quite a lot in the resource-poor world, and you talk to people about it, and they say, well, I've never heard of that, but that's fantastic. And so it's rolling out this model and actually getting people to get the confidence to actually use this in clinical practice. So the best way to utilize these models is to take your individual patients, or perhaps your individual population of patients, put in the data which that patient has, that is the viral load, the CD4 count, previous drugs that the patient has utilized. Clearly, if you have a resistance test there as well, you can enter that, but most patients aren't going to have that. Out of that will come various different combinations which you could utilize. Additionally, you can actually put into the model, we have only these drugs. You can also put in the price of those drugs, because unfortunately, wherever we are, cost is going to be important. And then you can get an idea of the ranking of the drugs, the chances of success of lots of different combinations. For some patients, the top ranking one may not be the best one for that patient. If a patient has a comorbidity or an issue which means they can't take that individual drug, but you can see what percentage of chance of success you lose by not using the top one. And therefore you can balance things out with that individual. Of course, it's not just about sitting there playing with a keyboard. It's also about the clinical knowledge of the drugs and the patient, which must be factored in as well. When we're putting the data into the model, we have to think about what we're really trying to achieve. And I think with any treatment we give for any disease, it's about effectiveness. Clearly, we need to think about toxicities, adherence, but it's about effectiveness. So this model is telling us what is the probability with individual regimens of success. And when we're defining success as regards effectiveness, we're talking about getting the viral load to an undetectable level below 50 copies per mil, so down at very, very low levels. So this system is going to be used in people who have virologically failed previous regimens. So it's going to allow us to identify what is the best regimen with the best chance of success for that individual who has already failed therapy. So the RDI model can be used by anyone. It can be used by us in the United Kingdom. It can be used in the resource-poor world. I think it's mostly going to be used in those places where there is availability of a limited number of agents. We have a limited chances of getting it right. We have limited clinical information as regards time of failure, etc. It's going to be in those areas where we need to get things right first time. And any information which may actually help that is going to be absolutely vital in our fight against HIV. The real benefits of this system can be looked at in various different ways. Firstly, for the individual. Virological success means no infections, no tumours associated with HIV, and indeed, potentially a normal lifespan. So for the individual, getting the treatment choice right is essential. Secondly, at a population level, getting the treatment choice right in that individual is also essential. That's because there's risk of transmission of HIV. If you've got ongoing viral replication, you may pass it on to others, potentially with the resistance already present. And also it's about stopping the predominant viral strain in that population actually being a strain which has resistance, because that can cause a great deal of problems in the future. Other benefits of the RDI system, particularly in a resource-poor setting, is the potential for cost, that actually keeping someone well is clearly cost-effective. That's the first thing. But secondly, the model also allows us to factor in the different costs of different agents and see, by using potentially more expensive drugs, are we really gaining in the chance of success? Or can we get the same overall results by using cheaper options in that patient? The RDI model is free to any user. There is no cost, there's no hidden costs. People are giving their data into RDI for nothing. RDI is making this system available to the clinician or anyone who wishes to use it totally free. It's very easy to find. You just go to the RDI website, there it is. It asks you some simple questions about your patient. You plug in the answers and boom, 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 your answer's there for you. So HIV treatment is now highly effective. I think for anyone who takes their treatment properly or is able to take their treatment properly, you should be looking at 100% success rates. There will always be people who fail. We need to make sure in the future that the chances of failure is as small as possible. And that's not only about drugs, it's also about choosing the correct drugs, it's about the side effects of those drugs, and also about supporting individuals with HIV. And that's the same whether you're living in the resource-rich or the resource-poor world. We need to make sure that drugs become available for all, that their monitoring is available for all, and that we are able to have all the information necessary to make the correct choice. While we're waiting for that dream to happen, however, we have to really use the resources available to us. So the future is looking rosy. What we need to make sure is those patients are able to benefit from any advances in the future. And they are going to benefit from those advances from being there, being well, which means suppressing their virus fully by making the best choice of agents for them. So I think here at the Chelsea and Westminster, it's always a time of change. I think that we are a large centre. We're lucky enough to have very dedicated physicians and nurses here. We will continue to be a major player, I think, in this country. We will continue to be a major player as regards development of new agents, new research. I think increasingly, though, there's a realisation that the knowledge that we have here has to be translated outside of this centre, outside of this country, and into a resource poor area, and we can use our knowledge as regards education, we can use our knowledge as regards patient treatment. We can also look at the knowledge not only as regards clinical knowledge, but also management, so general, how best do you run your clinic? You know, we've been through several changes here. And I think what we need to look at the Chelsea and Westminster, and indeed we're doing so, is partnerships. And it's about partnering. So, you know, I myself, I've got partnerships, big partnerships in Uganda, in Myanmar, in Vietnam. Others have different partnerships. And so it's all about that partnership. And RDI is one of those partnerships that with us and with the other people involved, hopefully will allow great improvements in the resource-poor world. So it actually matches, or indeed perhaps even does better than what we can achieve in this country. I've been involved with HIV since I qualified, so I'm not going to tell you how many years ago, but I am going to join the 25-year club here, so there's a bit of a clue. So we've clearly here had a lot of experience, we've made lots of mistakes, as have others, and it's about taking that experience and actually making sure people don't repeat those mistakes. And I think the partnership with RDI allows us to translate not only our knowledge, but the experience of many, many patients who have lived with HIV, some of whom have died of HIV, and making sure that those individuals who are now in need of information allowing best choice of treatment can actually gain from that knowledge, from those mistakes made in many, many brave people who've lived and died from HIV disease.